I'm Dr. Shushil Patel. I welcome you all to the IDCM Metacon 2023. So in the sequence, this is our second conference. This is the annual conference of IDCM. So IDCM is a body which is working in the field of diabetes and cardiometabolic disease. We have the different features in the IDCM, and one of these is the annual scientific meet. That is a national level meet where we invite the speakers across the India, and we discuss all the topics related with the diabetes and the cardiometabolic disease. So to start with, the basics of all these things are the nutrition. So for this, not wasting much of our time, let's begin this scientific extravaganza. First, our symposium is, we have the different associations which is collaborating with us for this scientific event. And first association is Diabetic Association of Baroda, which is working for the type 1 diabetes children and the diabetes awareness in the society. So this symposium is dedicated for the Diabetic Association of Baroda, and that is a nutrition symposium. And to chair this session, I invite Dr. R.S. Nanavati sir and Dr. Ashwin Bhatt sir from Khambat to the dais. Welcome, sir. And I request sir to introduce our first speaker so that we can begin our scientific program.
Good afternoon, everybody. This session is on the dietary guidelines for diabetes in practical. We have Professor Vanessa Nambiar with us. She will be talking on ADA guidelines for diet on diabetes. She has experience of 29 years of teaching at Baroda University, Home and Nutrition Department. She has a lot of awards and publications. She has completed 29 projects for research. She is Vice President of International Society of Medical Food and Nutrition. She is Vice President of MSU FNA, Coordinator for NPRINDIA Resource, and Deputy Director for Office of International Affairs, MSU Baroda. And she is with us at Diabetic Association of Baroda as a trustee. Madam, so please. You have 10 minutes for your...
Thank you, everyone. Thank you, Dr. Nanavati, sir, who is a pillar of Diabetes Association of Baroda, always supporting. And thank you, the organizers of Metacon, for giving me this invitation and involving Diabetes Association of Baroda for this very august, very intellectual gathering, Metacon. I bring to you greetings from one of the finest university of India, the Maharaja Sayaji Rao University of Baroda. And my humble thanks to all the partners of Metacon for organizing this gathering of intellectuals. Today, I'm going to talk about the recent ADA Standards of Care, which has been released in 2020. And the overview of my presentation is as follows. I'm going to talk about the current scenario of diabetes and need for revised guidelines, and what's new in this ADA Standard of Care. We all know that the trends of diabetes is on the rise. So is the GDP, and so is the scientific endeavor happening in this country. We are today going to launch Chandrayaan. And as I speak, something very historic is going to happen in our country. But at the same time, we need to be concerned about the rising trends of diabetes, and these figures are from the Diabetes Atlas 2021. The number of adults with diabetes in India are over 20 million, and the number of people with diabetes are going to increase as shown in this figure. And India is ranking number 2, which is again a cause of concern. And more cause of concern is proportion of adults who are living with undiagnosed diabetes. When we look at the RSSDI consensus recommendation for insulin therapy, the first thing that you can see on the top is healthy diet. After that comes control of weight and physical activity, and then comes the treatment of diabetes with drugs. So how do you actually treat diabetes? And for that, you need to understand the categories. The first, type 1. Second, type 2. The third is the hybrid form of diabetes, which had 2 names. The first one, which was previously known as the LADA, latent autoimmune diabetes for adults, which is a slowly evolving immune-mediated diabetes in adults. And the second is the ketosis-prone diabetes, which was previously known as the Flatbush diabetes. Then there are other specific types, unclassified, and therefore diagnosis of diabetes is very important before a dietary advice is given. These are the criteria for prediabetes, intermediate hyperglycemia, and confirmed diabetes. And the RSSDI consensus recommendation also refers to the ADA consensus guidelines for diet, which is 2019. So, with this overview, let's talk about the ADA guidelines or ADA Standards of Care released in 2023. We had the clinical practice recommendation in India by the Research Society of Study of Diabetes in India in 2022. And now I'm very happy to announce that RSSDI, with whom I'm associated with as a member, has invited me to be a part of the core team of the RSSDI Nutrition Guidelines 2023, which are under process and will be launched shortly for the Indian population. So what is this ADA guidelines? These ADA guidelines or standard of care are for people living with diabetes and include updates to recommendations around obesity, hypertension, heart failure, medication, social determinants of health, and lipid management. With Ms. Dr. Nuha El Sayed as the chair, this committee of AD, like our RSSDI, is also comprising of the multidisciplinary team of 20 leading US experts. And the ADA grading system, like we also do in the RSSDI, uses A, B, C, D methods, which is displayed over here. So what's new in these standard of care? Number 1, it emphasizes on supporting higher weight loss, up to 15%. Earlier, we said 7% weight loss leads to reduction in HbA1c, so now it's 15%. There are new recommendations related to sleep health and physical activity. We have a whole session on circadian rhythm disruption and chronomedicine and biology by Professor Narsingh Verma, with whom I'm also associated with, and I strongly advise everyone to please attend the sessions to understand how sleep and circadian rhythm disruptions have strong evidence in the onset, prevalence, and management of diabetes. The new recommendations also talk about social determinants of health and the guiding design of delivery of care. It talks about the new hypertension cutoffs. It talks about expanded role of SGLT2 inhibitor, which I see very clearly mentioned in future sessions. And for kidney diseases, it talks about role of finerenone. Then there are new lipid management recommendations, and it suggests lower LDL goals for high-risk individual. The 8th point talks on digital health, telehealth, and telemedicines. Then the 9th point talk about POC, A1C testing, and the 10th point talk about NAFLD, now also MAFLD, which is metabolic aberrations and liver disorders, which is again a very, very missed out point in diabetes care and is included in the new ADA guidelines. The 11th one talks about screening on food security, my very favorite topic, by every member of diabetes healthcare team, and that can happen when you hire a qualified nutritionist, so please do so. The 12th one is the use of technology in older adults with diabetes. 13th is use of person-first and inclusive language, updates and vaccination, and the 15th point talks about COVID-19 and diabetes. Now, when we look at technology, the blood glucose monitoring and the CGM, continuous glucose monitoring, is emphasized, and the need for putting up CGM, especially for the newly detected diabetics, is greatly emphasized, because that actually tells you which part of the diet or which part of the day you're getting hyper or hypo, and how you can easily change the diets. The 5th one talks about social community support, includes chronic care model, which is very, very person-centric team care. So treating diabetes is not just limited to a physician. You need to have a good team, including very good qualified nutritionist. So care systems should facilitate team-based care, is what the ADA emphasizes. It should have multidisciplinary team, which ADA emphasizes, and telemedicine may increase the access to care for people with diabetes, which I think most of us have learned during the COVID-19 pandemic. It talks about behaviors. It talks about social behavior change communication, a subject which we teach in our Department of Foods and Nutrition, and it has a very systematic approach. The ADA guidelines talk about diabetes self-management, education, and support. It also emphasizes on lifestyle behavior change for diabetes prevention and eating variety of foods, and it should be based on patient's preference. As far as diet is concerned, it is very clearly mentioning this statement that there is no ideal percent of calories from carbohydrates, protein, and fat. And it does talk about very low calorie diet, and keto, which is going to be taken by my colleague, Dr. Komal, shortly. It talks about assessment of dietary intakes. Now, this is also a very specialized field done by the nutritionist. Which method to use, how to assess, how to put it, and then you calculate the percent RDA, and therefore, based on that, you guide your medicine and physical activity. The next point is on positive health behaviors and maintaining psychological well-being. You need to understand the root cause for maximizing quality of diabetes. So this diabetes self-management education and support is very, very important and needs to be assessed at 4 critical times: at diagnosis, annually, when complicating with different factors like physical, medical, or psychosocial, and when transitions in life. The MNT in diabetes is going to be taken by my next speaker, so I will be only talking about that it should be personal, should have cultural preferences, and the diet prescribed should have pleasure in eating, because food is all about society eating, and then that should be, you should be giving practical tools for developing healthy eating practice. When you look at the treatment of diabetes, whether it is diet, physical activity, behavior counseling, pharmacology, or surgery, diet is #1 in any kind of treatment, and therefore it cannot be ignored. The other parts will be social determinants of health, weight maintenance program, and these weight maintenance programs should be having support groups. And it talks about minimum physical activity every week, around 200 to 300 hours. The next is about having trained practical practitioners in medical setting with close monitoring is what is recommended by the ADA. And the last point about metabolic surgery with which is my very close topic is patient pre and post metabolic surgery should receive long-term medical behavioral support and routine monitoring of micronutrient, nutritional and metabolic status. These metabolic surgeries are in vogue and I'm just finishing, can be restrictive or malabsorptive strategy, and they have very, very specific nutrition advice, whether it is MGB or RUGB, RYGB, and the nutrition counseling has to be there. And the last but not the least is GDM and its management. The counseling has to be pre-conceptual. So thank you so much, and I once again thanks the DAB as well as the organizers for giving me this opportunity. Thanks.
Good. Thank you. The next expert speaker is Dr. Swati Dhruv. She is from Department of Foods and Nutrition, Maharaja Sahaj University, Baroda. She has 22 years of teaching experience. Area of specialty is clinical nutrition and dietitians and adolescent nutrition. 12 research projects and 2 copyrights. 25 research papers published in national and international journals, presented around 100 papers in various conferences, 22 award papers at national conferences, editor of the book entitled Food Safety, Security and Sustainability Perspectives, developed nutrition through lifestyle-related modules, published by MHRD and NAVICT, member of the Joint Review Machine Midday Meal Scheme of Gujarat and Maharashtra, Government of India. Member of State Level Steering Monitoring Committee of Midday Meal, Gujarat Government, member of Micro and Macronutrient Program Monitoring Team, invited as guest speakers and nutrition experts as various programs. Welcome, Dr. Swati.
Thank you so much. At the outset, let me thank IDCM for having invited us over here and giving us a whole session on nutrition. So thanks a lot. So as Vanisha has already briefed you all about the ADA guidelines, so directly we'll be talking about the management of diabetes. Per se, what we are going to be discussing over here in these 10 minutes is only going to be about carbohydrate counting, because that is something which is very important. Of course, we do have the glycemic index, the glycemic load. These are also the concepts that we do use. But first and the foremost, what we would be talking today, I would be restricting myself only to the carbohydrate counting. So as we all know in our Vedas, we have said that aham annam, so we are what we eat. And that is the reason we are here, because what we eat is the one that decides how much is going to be our postprandial rise in the blood glucose levels. So what we as nutritionists and dietitians, what we recommend would be that you eat right. Right? So as we all are aware, this August gathering is aware about the macronutrients that are present in our diet. That would be carbohydrates, proteins, fats, etc. However, the main nutrient of concern today would be carbohydrates, because that is the one basically which affects the blood glucose levels. And as we are aware that it goes straight into the bloodstream. So as you can observe over here that when you have had a carbohydrate meal or a diet which is high in carbohydrates, then definitely within an hour or 1.5 hours maximum, it would reach the bloodstream. Whereas that means the level of glucose in the blood after a meal will be directly related to the amount of carb that you have had in your diet, basically. And if you compare this with the protein and the fats that are present in our diet, you can have a look over here that proteins approximately it takes around 2 to 5 hours to reach the bloodstream, whereas fats and all that is in order to raise the blood sugar levels. That's what we are saying. And fats and oils approximately 4 to 6 hours. But this does not, however, warranty that we can have as much of fat in our diet. So whether we are using the glycemic index concept, the glycemic load, or the carb counting that we are talking over here right now, one has to be very cautious when as a nutritionist or a dietitian, you are recommending to your patients, because blindly you cannot recommend to them that you consume foods which are rich in fat. For example, if you take a samosa, right, which we all are very, we eat with so much delicacy and all, we like to always have it. That is once in a while, as a nutritionist we would recommend. So if you take a samosa, it has a glycemic index which is low to moderate. That is, the reason is because it has lot of fat, it's a fat laden product. So that is not, so if you, based upon the GI blindly if you recommend, we cannot recommend it even to a diabetic patient, because it would lead to heart disease, the secondary complications and all it would invite. So one has to be a little cautious, but here right now what we are saying is only about the carbohydrate counting. So carbohydrate counting, as we all are aware, that is where we count the amount of carbohydrate. So we are aware of the foods which are rich in carbs, but along with that, what we need to know is that how much is the amount of carbohydrate that is present in those foods which are containing carbohydrates. Why we are concerned with this is because there needs to be a balance with the amount of carbohydrate that we are eating and the insulin. So that is the one, when there is a balance, then that would decide how much is going to be the rise in the postprandial blood sugar levels. That means we need to know, as I mentioned, one is which are the foods which are rich in carbohydrates. The second part is how much is the amount of carbohydrate that is present in these foods. And one carbohydrate counting, when we take it, it equates to approximately 15 grams of the carbohydrate that is present in the food. And when we have a very good balance, that is, with practice, the diabetic patient can learn to have a good practice. So what happens is, when you are able to count the carbs that are present in your diet, then definitely you have more food choices. The reason why we are talking about carbohydrate counting is, for a diabetic patient, they would be having good choices, they would be having more choices from amongst the foods that are available, as well as that would help in better control of the blood sugar as well as the HbA1c levels. So one is, this concept came into existence because this was specifically meant earlier only for the type 1 diabetics. That is, that they can, why count carbohydrates? That would be to follow a meal, to use an insulin to carb ratio. And also this holds good even for the type 2 diabetics. That is, it would help them to follow a meal, use the insulin to carb meal ratio, and also portion control. It would help in controlling the portions. So then comes the question that how much should be the amount of carbohydrate that people with diabetes should be consuming. So now definitely, as we all are aware, that it would vary with your age, gender, height, weight, etc. And of course, your dietitian or your doctor would give you that this is going to be your carbohydrate target, this is how much you should be consuming. So if we have a look at how much would be the limit or how much is a recommended amount of carbohydrate that you should be having in your meals, as well as in your snacks. So in case of females, if you take, that would be approximately 30 to 60 grams that you can have in your meals. And in case of males, because of the more muscle mass and all, it would be 45 to 75 grams. And with respect to snacks, in case of females, women, it would be 15 to 30 grams, and in case of males, that would be the same. So in case of snacks, it is the same. Only in case of meals, there is a difference given with respect to males and females. Now, when one is a diabetic, of course, here we have a fraternity which are doctors and all and dietitians and all, but for a layman, when you take, whenever they are diabetics, the first thing that would come to their mind and the thing that they would consider or controlling would be only sugar. So only in their tea, coffee and all, they will think that, okay, I am not having tea, sugar in my tea, coffee, etc. So my control is done. But that is not the case, right? Because carbohydrates, any kind of carbohydrate, which we just saw in the previous graph that I showed you, that it is going to raise your blood sugar levels. So the carbs that you need to count are basically both starches, which take a longer time to break down, as well as simple sugars, which break down quite quickly. So starches, all foods you need to consider when you are counting the carbohydrates, that is starchy vegetables, even legumes, grains, and sugars when we are talking all of this, fruits, fruit juices, bakery products, sugary drinks, milk, yogurt as well. Then definitely the question that would come to one's mind would be, what about the proteins and the fat? But see, for foods like the macronutrients like proteins and fats, They do not have that much impact on the blood sugar levels directly. Indirectly, yes, they do have, but directly they do, because of the fact that they have negligible amount of carbs that are present. So you do not have to worry about them when you are doing carbohydrate counting. You do have to worry about them when you are prescribing a whole diet to your patient, but when we are doing carbohydrate counting, at that point of time, we do not have to worry a lot about them, right? So, this is how you teach to your patients. We'll just have a glimpse of that. That is when, see, because to a layman, as a dietitian, nutritionist, we would know that teaspoon means 5 ml, 1 cup is 200 ml. A layman would not know that. So for a patient, you have to educate the patient that the tip size would be 1 teaspoon, for example. 1 ounce means 30 ml, that would be the thumb size. Handful, half a cup, so on and so forth. So this is what you have to educate to your patients. Then once they have the practice of it, it is quite easy. So we'll just have a look how much is the carbohydrate content present in various Indian foods. So I have just highlighted a few of them. For example, just 2 minutes. 1 slice of bread, if you eat, it would have 15 grams of carbs. If you have 1 chapati, which we are all used to having every day, having a 6-inch diameter, that would also, if you have half a cup of poha, right, that is without potatoes I'm talking, it will have 15 grams of carb. Similarly, if you take tur dal, right, arhar dal, the red gram dal that we eat every day, half a cup would have approximately 15 grams of carbohydrate. Again, over there, whether it's thin, medium, and thick, that we have to consider. Then we have sweets. If you have half cup of ice cream, it will have 15 grams. If you have 2 small naan khatais, that is going to have, if you have 1 small ras malai, it will have 15 grams of carbohydrate, right? Sapota, that is chiku, if you have 1 medium, it will have 15 grams of carbohydrate. So on and so forth they have given over here. So we'll just take 2 or 3 examples to just give you an idea how do you calculate. For example, we'll talk about the snacks. So the onion poha, as I mentioned, without potato, it would have 15 grams of carbohydrate, 20 ml of milk, another 5 grams, 1 fruit, if you take an orange, a medium size, 10 grams. So total would be 30 grams. So that means if the patient is on insulin, type 1 diabetic, so it would be 2 units of insulin that the patient would have to take based upon the amount of carbohydrate that is present in the diet. Similarly, for those from down south and all, 1 small idli, half a cup sambar, that would equate to 30 grams of carbohydrate. So again, 2 units of insulin. If you are from north side, up north, you would be accustomed to eating parathas. So it would be 3/4 of the potato, that is aloo paratha, or half of paneer paratha. Along with that, if you are having chole, half a cup, and 1 fruit, that would amount to approximately 45 grams, which equates to 3 units of insulin. The last part, this is just a paper that I found that has been published in 2023 January, which has, because all these, when I tell you, for a layman, sometimes it's difficult to understand, how much is the carbohydrate counting, how much is the amount of carbohydrate in the food. So they have tried to simplify the carbohydrate counting. So what they are mentioning over here is, when as a dietitian and a nutritionist, you give it to the patients, you need to have, the insulin, you customize it and give it to them. Don't give them pages and pages of the thing. You know what is the usual diet of your patient, right? You have taken the 24-hour dietary recall. So customize it and give it to them. Then based upon the insulin sensitivity factor, insulin carb ratio, and the blood sugar target, you give them that, okay, 1 slice if you are having of bread, 2 units. So what they have to do is they just have to add up the insulin sensitivity ratio and all, and then they would come to know exactly how much is the amount of insulin that they have to take. Similarly, if you are on bolus, smart bolus pump, the insulin pump, similarly you can give it in this fashion to your patients. So just summarizing that, so management, when we are talking, definitely diet, physical activity, and medication, whether you are on OHS or on insulin, that would be what you would have to consider when you are a diabetic. And one must remember that you are responsible for your own health. Thank you.
Hello. Thank you, Dr. Swati. In a very short time, you have given a very big things. Our